I'm Jimmy Gubler, owner, founder of Spine PT. We specialize physical therapy, just focus on the spine. Not having disclosures. I'm going to have everybody start by doing a demonstration. If you could stand up. Now, if you have a back issue and you don't want to do this, you don't have to do it, but I'm going to have everybody just kind of put their hands on the front of their legs and how far can you go towards the floor? Okay, just kind of pay attention to how far you can go. Okay, everybody now stand back up. Now I'm going to have you just bend your knees slightly, and then you're going to take your fist and you're going to karate chop right, your infrapatellar tendon, so right below the patella. You're going to do it repeatedly for 10 seconds. Just keep pounding and see if you can get your quads firing while you're doing this, okay? Okay, everybody now recheck again and see how far you can go towards the floor. Okay, everybody gonna sit down now. How many went farther the second time? If you didn't, then you didn't do it right. You didn't have quite the right angle. You weren't eliciting the quads. But so what we demonstrated there is the hamstrings can be inhibited by the quadriceps, okay? And then what happens in cold water to our muscles? Are they nice and relaxed? No, they're all tense. Why is the body tensing up when we get in cold water? It's a protective response, right? It's trying to protect us, hopefully conserve heat. What about if somebody's standing up here and you can't get out of the way and you can't block and somebody's going to slug you? What's our natural inclination to do to protect ourselves? Tense up muscles, right? So would everybody agree that the autonomic nervous system and our conscious actions to include contraction of muscles for protection? Is that a fair statement? Okay. Reflexes. What is the withdrawal reflex? Can my physical therapist? What is the withdrawal reflex? You touch a hot stove, pull away, right? What is this reflex called? Anybody? Startle. I heard it. Yep, the startle reflex. Now, what's interesting, nobody has been taught to do this, okay? But we all do it. Now, if you think about what's the most important part of our body that we can't live without, it'd be our head, right? If this is gone, nothing else is going to work. So our first impression, if we're startled by something that catches us off guard, the first response is to lean back, not only throw our hands up, but the fingers go apart to block whatever's coming at us, eyes popping open wide to help us see what's going on. And then a lot of times people will scream. Well, what would that do? That might startle whatever's coming at you and maybe give you a split second to defend yourself. Yeah, so this is amazing. The body just knows how to protect itself. So we're going to get back to reflexes because that's the heart of this discussion, but to help us understand that, we really need to talk about the immune system to see some similar reactions with the immune system. Can anybody think of an overblown immune response? Allergies, yeah. Is a swollen ankle an overblown immune response? Is that too much? Yeah. Everything the body's dumping into that ankle is good stuff. All the white blood cells, neutrophils, macrophages, all that stuff to clean up the damaged tissue and try to help it heal. But the problem is it's way too much. That's why you have physical therapists and athletic trainers working for sports teams. And we found that if we can control how much swelling gets in there and minimize it, they have much faster recoveries. Why do we use wound vacs? Because the body's dumping too much good stuff in there and you got to pull it off or else it's going to delay the healing. What about Dr. Gary Edwards just presented on compartment syndrome? Is that overblown response? I think so. I mean, you have tissue damage to a compartment where there's no room for expansion and the body's like sending all these white blood cells down there to try to fix everything, but there's no room and it becomes, life-threatening. So we can see that what we've learned as healthcare is if we can control some of what the body's naturally trying to do, we can actually get better outcomes. Another concept I really want you to understand is the concept of ischemia. And has anybody ever done a wall sit before? Who's done a wall sit? You've done a wall sit. Okay, let me ask you, Did you have any, did you have any weakness in the quads while you're doing that?
Oh, for sure. After a while, yeah.
How about burning sensation? Any pain?
Sure.
All three of those, right? So let me ask you, did you have any major tissue or structural damage to cause all that pain? No. So, I mean, you stand up and the pain, the weakness, burning goes away pretty quickly, right? So we always have this impression that, structural tissue damage, structural damage is what causes pain, but we can see that what happened there was you're getting pain from mild ischemia, okay? So Dr. John Sarno, in his book Healing Back Pain, attributes a lot of pain in the spine to ischemia. He theorized that repressed emotional stress triggers the autonomic nervous system to restrict blood flow, leading to oxygen deficit. So basically what's happening is if I were to take my fist and I put it in a bucket of water and then I pull it out and I open it up, you're going to find some dry spots in there because the tissue is so compressed it was not allowing water to get there. So it's in the same way, when we're contracting those muscles so much, the blood cannot get in the muscle to bring the nutrients and oxygen. And then it causes pain. And so what do? It forces us to move. Pain causes us to move, and usually that kind of helps. Can stress cause pain? I think anybody that's had stress, you can feel that tension forming across the shoulders, right? So stress is really a low level. I mean, think about the wall sit. What if I just barely bend my knees? I'm barely engaging the quads. If I maintain that all day, you can see that's going to have a slower but the same effect as if I do the full squat, but that happens a lot faster. So Dr. Darcy Umford was my neuro professor at the University of Pacific, and she wrote Neurological Rehabilitation. It's the textbook that most PT schools used back in the 90s. And during one of her lectures, she really made a point to have us know. She said, look, when other therapists find out I'm a neuro instructor, they always have to tell me, I'm not a neurotherapist, I'm an orthopedic therapist. She says, please never embarrass yourself and say something like that. She said, every patient is a neuro patient. Some happen to have an orthopedic condition. So what is she really saying? She's saying there's hardware, that's the orthopedic side, and there's the software of the body. That's all the programs that run the hardware. So if you ignore the software, you're not getting the full picture on the hardware. So that brings us back to our topic today. Let's talk about reflexes. Sir Charles Sherrington was an English physiologist. 50 years of experimenting, he kind of has laid the foundation in neuroscience for how the brain and spinal cord control movement, reflexes, and coordination. He wrote the book Integrative Action of the Nervous System, published in 1906, and because of that, he won the Nobel Prize in Physiology in 1932. So he's the one that coined the term synapse. He proposed the communication between neurons is not continuous, but occurs across gaps. He showed that the spinal cord integrates sensory inputs to produce complex motor outputs, even without control from the brain. So what does that mean? It means we've all done that before. We're walking, we step on something sharp. What happens? We have this withdrawal reflex, pull away, but not only do we have that withdrawal reflex, the opposite leg has to go into extensor reflex so we don't fall. So that's what he's talking about here. He introduced the concept of reciprocal inhibition. When one muscle contracts, its antagonist is inhibited. That's what we did with the demonstration of we are contracting the quads through the deep tendon reflex to inhibit or relax the hamstrings. He argued the nervous system does not merely react to stimuli, but it organizes and integrates inputs to produce meaningful, goal-directed responses. What better response could the body have than protection, right? So he showed that inhibitory control is essential for coordination. preventing unwanted muscle activity and allowing for fluid motion. So when I want to eat that hamburger, I'm contracting my biceps. I don't want my triceps firing, and throwing the hamburger from me. I need to have that controlled, graded movement to be able to use my limbs in whatever way I want. So when one's activating, the other one has to deactivate. So just kind of summary, reflexes operate independent of the brain. Reflexes can't think, they only respond to stimulus. And there's a connection between stress and our reflexes. So we're going to do one more demonstration. It's real quick. So I want everybody to find their masseters. Okay? If you can't find them, just clench your teeth and they'll pop out. Then relax your jaw, but feel them. Are they nice and relaxed, or do you feel any tension in that masseter? Okay? Now what I'm going to do is I'm going to randomly select 10 of you, and you're going to come up here and we're going to quiz you on neuroanatomy and some, see how well you know physiology. Okay, now I want you to check your masseters again. Did it change? Did anybody see a change? I didn't put enough fear in you guys, I guess. So normally when people start feeling that fear, fight or flight response, they start feeling fear, their masseters will all of a sudden become a lot more ropey and tense. People can feel that difference. Okay, did anybody feel some tension in their muscles, the masseter? Okay, now we're going to do the opposite. Let's see if we can get it to relax, okay? So I want everybody to think of a memory that makes them smile inside. For me, it's like when I was 12 playing baseball. But think of a memory, and then at the same time, I'm going to have you stroke your chin like you're stroking a goatee. We're stimulating the mandibular branch of the trigeminal nerve. But think of that happy thought for just 5 seconds and stroke your chin, okay? Okay, good. Now, check your masseters again. What happened? Do they feel flatter, more relaxed? Does anybody feel it relaxed? Okay. Yeah, so what did we just show there? It shows that our thoughts and stimulating different nerves, just light stimulus can have an effect on the reflexes. So I'm going to share a case study. In 2001, I opened my first outpatient clinic in Ohio, and I really heavily focused on the spine. And I had a call there's a neurosurgeon, Dr. Michael Shannon. He was right outside of Columbus, Ohio, and he loved my clinic and sent me all his patients. And he called me one day in about 2003, said, "Jim, I'm going to refer this patient to you. He has a large herniated disc at L5S1, and I suggested we have surgery in the next 2 weeks." Now you got to understand, Dr. Shannon was booked out for 3 months. So for him to bump this guy up to 2 weeks means that he felt he was really serious condition. But Dr. Shannon was a very popular and well-known neurosurgeon, so that's why he had such a long wait list to get in to see him. But he was bumping him up the front of the line in 2 weeks. But he said the patient's young, and he said, "I'd really like to try something conservative before I have surgery." He's like, "Well, I'm going to send you to Jim. He specializes in the spine, but he's like, let's go ahead and set up the surgery in 2 weeks. I'm sure you're going to be back, and then we'll be all set up to move forward." So he said, "I'm going to send you the MRI. Good luck. I'm sure you're going to be sending it back to me." And then he hung up. So I got the email, opened up the MRI, and it was the worst MRI I'd ever seen for large herniated disc. And I remember thinking, I don't know why he's even bothered sending him to me. I think he just needs to have surgery. And so here's what the guy presented with. And when he came in, again, it confirmed, I'm not going to be able to help this guy. This guy is too bad. So he was a young 32 healthy male, prison guard. He was attacked 2 months earlier. One of the inmates attacked him, grabbed him, and then he fell back onto his back and buttocks. And ever since that time, he'd had severe pain, 9 out of 10. The lowest it could get to is a 5. He was miserable for 2 months. It took him 2 months to get in to see Dr. Shannon. He couldn't work. He couldn't do anything. He was bedbound, severe pain, and dermatomyotome, all consistent with L5S1. He was stuck in about 30 degrees of trunk flexion, and he could barely walk the 50 feet back to the treatment area. He had no loss of bowel or bladder function. He couldn't move more than just a few degrees from that flexed posture, and palpation, all his muscles were locked up. So let me ask you this, is a herniated disc, is it a hardware issue or is it a software issue? How many people think it's a hardware issue? Yeah, that's what I think, it's a hardware issue, right? So I thought, okay, how am I going to treat his hardware? And at this time, back in 2003, I had just been introduced some new techniques and some concepts related to Sherrington's work about the reflexes and be able to inhibit muscle groups and calm muscles down. And I thought, I wonder if I should try, if I can just relax some of his muscles, because he is so locked up, then maybe I can get in there and allow me to do more hardware treatments, the mechanical stuff. And so I tried. I reciprocally inhibited his psoas, hamstrings, quads, glutes, hip flexors, adductors and abductors, paraspinals, multifidus, and QLs. And he's laying on the table. I'm like, how you feeling? He's like, actually, I'm feeling really good. I said, okay, well, actually, let's stand up and reevaluate. He just rolled off, no problem, stood straight up, and he said, I don't have any pain. Like, okay, this is weird. How's your movement? He bent over, touched his toes. And he went backwards, and he was almost ready to do like a back handspring. And I remember telling him, "Oh, hold on, you're going to hurt yourself. Don't do that." But I mean, he was no fear at all. He was just totally going back, going forward. Nothing. 100% symptoms resolved. And I was thinking, what in the heck just happened? It just made no sense. I thought I'm just going to relax the muscles, and I can get at the hardware. And I wasn't prepared for him to be completely asymptomatic. In fact, I was so stunned, I'm like, I didn't know what else to do with him at that point. I mean, he was totally normal. So I'm like, well, let's set up an appointment for next week and just see how it goes. I didn't know what to expect. 3 weeks later, I realized he never returned. So I had my receptionist call him and came in a week later. So 30 days later, completely pain-free still. He would return to work. I said, well, where have you been? He said, well, I haven't had pain. I've been working on my dad's boat. I went back to work. I didn't think I needed to come back in for therapy. I'm like, yeah, I guess you don't. So you got my number. If you have any more problems, come back and see me. 3 years later, I was walking through my neighborhood, and here comes this same guy. Apparently, he lived not that far from me. And first thing I wanted to know is like, how you doing? What happened, And he's like, I'm still pain-free. No problem. Never had any issues after that. So let me just kind of briefly share some of my experience so you know where I'm coming from. Is I went to physical therapy school to fix myself because when I was high school, I had a sports injury. I thought I broke my back. It was really severe pain. Gradually, it kind of got better, but then my pain just kept coming back and back, and it turned into neck issues. So I was struggling for 10 years before I got into PT school. I went there to fix myself because I tried a lot of other, chiropractic, other physical therapy, and saw lots of different doctors. Nobody was able to really help me. And what I figured out was it was my disc. I had a lumbar disc issue, and so what I did is I started experimenting on myself. I found, oh wait, sitting this way helps my back. This way makes it worse. So I started finding, there's no one perfect way to sit. We can get the disc in a good position, but the rest of the muscles are not really happy if you sit that way for 8 hours. So I found a bunch of different ways to sit. And so I created a bunch of books and videos for my patients all about sleeping positions, sitting positions, how to lift, how to do all these things that were I was struggling with, was causing my pain. And once I figured out how this all worked, my pain went away. And this works amazing for my disc patients. I get people better so fast. In fact, a lot of it's hands-off. It's just more education, and they're getting themselves better, empowering them. But these are all 100% focused on hardware, and that patient, I didn't do any of this with this guy. So the question I have is, was the herniated disc causing his pain? How many think the disc was actually the root cause of his pain? You think that it was the cause of his pain?
I'm an engineer. It seems like it was pinching.
It would seem that way. That's what I thought, but if I didn't do any hardware treatment, how would, and I'm just in 3 minutes, it took me 3 minutes to calm his muscles down. That's why I'm thinking, I don't think it is a hardware issue. I don't think that in his case, can it? Yeah, absolutely. We know that hardware and a herniated disc can cause the pain, but in his situation, I don't believe it was. I believe it was an overblown immune response of his protective reflexes. We call that an upregulated autonomic nervous system. So I'm not going to go into the MRI, all the data, but here's 3 main points from the literature that seem to talking about MRIs. A positive MRI does not necessarily equal a pain generator. Studies show that many people with herniated discs on MRIs are asymptomatic, but the consensus is that we need to combine the MRI with the neuroexam, the myotomes, dermatomes, reflexes, patient history. All that needs to be factored in, not just relying on the MRI. So has anybody here, besides myself, had a patient come in, like their symptoms are the MRI shows a large herniated disc at L4, L5, but their symptoms are L5S1. Has anybody ever had that discrepancy, like the dermatomes, myotomes, all at a different level than the MRI? So what do we do in that situation? Do we have any doctors that do injections? Oh, there we go, Dr. Gross. So if you saw somebody, the MRI said L4, L5, herniated disc, but then their dermatomes, myotomes are pointing towards L5S1, where would you do the injection?
When you treat the patient, not the image, right?
Yeah, so you'd go for the L5S1 probably. So even palpation.
The insurance game we play, right? So if I'm honing on an L4, L5, like insurance doesn't understand the transcending nerve route past the L4, L5. And so they'll oftentimes deny if you're suggesting L5S1.
That's what I was kind of wondering, because I had this exact situation. A patient came to me and her symptoms are all L5S1, but the MRI showed L4, L5, and she'd been injected twice at L4, L5 and no change in her symptoms. So I treated the L4, L5S1 and she was better really quickly. So I kind of wonder if the insurance is what's kind of forcing, okay, no, you need to go here. This is where it shows the problem is. But I didn't know how much flexibility you have on that. So could this also explain why, we've all had those patients that with car accidents, they come in, they're in severe pain, but the MRI shows nothing's wrong, right? And I see these patients and it's kind of sad. Sometimes they're almost tearful because they feel like nobody believes them. They're like, people think I'm just seeking drugs, or I'm a malingerer, or I'm trying to get out of something, or it's like, I'm in a lot of pain. I put my hands on them and I can feel there's a lot of tension and hypomobility that they can't even fake. So the question is, does this type of calming the reflex system work with every patient? And unfortunately, no. Only about 1 out of 50 people that will respond like that first patient, whether have complete resolution of their symptoms. But when that happens, that 1 out of 50 people, like that gentleman, it's like really cool to watch. The facial expressions, people are just in shock. I'm in shock. It doesn't get old anytime I see somebody that happens with, but unfortunately it's only about 1 out of 50 that have that complete resolution of their symptoms. But the good news is that 80 to 90% of my patients do respond to this technique at various levels. So on the low end, they're improving at least by 25% reduction of their symptoms, but on the higher end, it's usually more like 60 to 80%. So, and what we found is if I can reduce their pain by like 60%, their range of motion will go up by around 60%. So it's kind of coordinated that way. And unfortunately, there's about 10 to 20% of people that it does nothing for them. They don't see any changes initially. But if I start into hardware type of treatments, I'm really starting to move the tissue, and I'm starting to bring their pain down, then usually by their second or third, fourth visit, they start responding to this type of a treatment as well. So why is this helpful to, before we just jump in and start treating hardware is on the conservative side, why would it be helpful to calm the nervous system? Well, has anybody ever had a baby and you giving them a sucker? Yeah, have you tried to take the sucker away? Are they gonna like that? No, they're not gonna like it at all. So, but that's how a lot of our treatments are. We're trying to take that sucker from the baby, and that's really not the best way. What if we take some shiny keys and say, hey, look at these keys over here. That baby is gonna get distracted. Oh, what's that? It's gonna drop the sucker, and it's gonna reach for the keys. And if we can keep that baby distracted long enough, it will actually forget it had a sucker, and it will be content with the keys. So that's actually what I feel like I'm doing when I do these types of techniques. And what happens is we get so much faster results when we combine software with the hardware type of techniques. Most people are better in 3 to 6 visits when you do that type of a combined treatment. And it only takes a few minutes to perform, you know, and patients love it. So talk about fibromyalgia and chronic fatigue. Is stress associated with either of these conditions, do you think? Yeah, so these are some of the people that for many years people thought they were just faking it because they can't see anything on the MRI, right? So these people respond really, really well to this type of treatment because so much of their nervous system is upregulated, it's just so tense, and you can't see it on an MRI. So, you know, usually 3 to 6 visits, they respond really well. Another question I get is like, well, hey, would this work for somebody with stroke or traumatic brain injury, you know, when they have that hypertonicity? And unfortunately, no, we don't see great carryover. Is there some benefit? Yeah, I've had some patients with traumatic brain injury that I was working with. They had some back and neck issues as well. But so if they've got a hypertonistic, you know, bicep, then yeah, if you're trying to straighten their elbow, if you overstimulate the tricep, you will get it to open up. But what I found is there's no carryover. It doesn't seem like it's lasting and holding and like it does with pain. We can actually, it's like we're rebooting the computer in the body, and then it just starts over again. But with this, it's not a long-term fix. So application here. Thinking, how does this apply for our doctors in the room? I really can't see anything that, useful for what you do. We need you guys to continue to be the best at the hardware, because when people need their hardware fixed, you guys need to be there to fix that. But what I'm hoping is that this has just kind of opened our eyes a little bit to like, hey, maybe there are some other things here, and maybe, you know, there are some other options for people with a large herniated disc or something that looks pretty scary in the MRI. As long as it's not an emergency. If somebody has an emergency, you know, they've got a cauda equina syndrome or they're paralysis or they've got an infection, obviously take them into surgery. I mean, don't try this. But if there's, most of these people, they're like, okay, this looks severe, but you have to wait a month or 6 weeks before you get them in for surgery anyways. What does it hurt to try going, hey, let's get to a clinic that treats the software and the hardware and see what happens, you know? You'll be surprised how many people are responding to this type of a technique. For our conservative practitioners, you know, we always need to be expanding our toolbox, and we need to make sure that we're including techniques and approaches that include the software as much as the hardware. And just remember, every patient is a neuro patient. Some happen to have orthopedic issues. Thank you. Any questions? I think we might have 30 seconds. No questions? Okay. Boss says no.